So I'll start with my involvement in sort of mental health issues and what led to my being appointed to be on this commission. So I'm the ranking Democrat on the policy committee, the health policy committee in the Senate. So I work on health policy issues every week, week in, week out. And in 2011, our state was moving forward on the issue of autism insurance reform. We have a lot of families in the state who are experiencing incredibly high medical bills that weren't being covered by insurance because a lot of insurers were just systematically denying that care, and we didn't mandate it in the state. And so as the bill started moving through committee and we started hearing stories, just overwhelming stories of how families were literally mortgaging their homes and turning in their retirement savings, trying to pay for the care that their children needed, I just kept being struck by the point that although those families really need care and support, we have a lot of other families who have children with other mental illnesses and developmental disabilities and pervasive developmental disabilities that also need our help. And so I became sort of the champion of a full mental health parity insurance plan instead of just the autism insurance reform, and started to gather some support with a lot of allies. And my intention was never to stop the autism legislation from moving forward, but to say, if we're going to take care of some of our families, why not all of them? That just seems like a much better decision. And frankly, I couldn't imagine being the person to look a mother in the face and say, oh, your child is diagnosis is on the autism spectrum. Your health care is now covered. Your insurance has to cover it. And to another woman to say, I'm sorry, your child's anxiety, your child's depression, your child's, what other diagnosis is not covered. So actually moved it forward far enough that we got the mental health parity substitute on the board for a vote in front of the state Senate, the first time it's ever had a vote in either chamber in the nearly 20 years that people have been working on this issue, and it fell one vote short. So the governor himself came to talk to me and said, we really want to get this autism insurance done. We really feel like it's a good first step, and if we show the insurers, if we show the healthcare payers that this is not the big financial boogeyman that they think it will be, then we can come back to a real conversation on mental health. And I didn't know him very well, and I didn't really know if I could trust him. We're from different political parties. We don't always see eye to eye on things, even though he is a constituent. But he said, if you help me do this, he said, I promise you we'll come back to mental health. So I did. I took his word and I trusted him. We got the autism insurance reform done. And the next year, he formed the Mental Health and Wellness Commission and asked me if I would serve. So that's where, and to me, that was him keeping his word, that we were going to come back, that we were going to look more holistically at how we do a better job of providing mental health care and services for this population in the state. So the charge, he issued an executive order, created it, defined the size and the scope of what we're supposed to look at, and it is overwhelming. It is a deep and broad charge to look at really every place in state government that touches this population, and it's everything from criminal justice and the court system to all of the different programs that we run. Many of them, it sounds like you are very familiar with because you're spending your time and energy there, from programs in DHS and community health to housing through MISHDA, veterans issues, our schools, you heard a little bit about that. Literally every place in state government that could be could touch this community. He wanted us to look and see what barriers there were to people accessing services and what gaps existed in those services. And so we went to the first meeting, and it's a little bit now almost legendary, but it might even sound just, I don't know, cranky or spicy or something. But I went to the first meeting, and I said, this charge is big, and it's broad, and there's a lot that we have to do. And I need the answer to two questions before we can go forward. And the Lieutenant Governor, on behalf of the Governor and the administration, chairs the commission. And so I look him right in the eye, and I'm like, okay, this is what I need to know. If you already have a preconceived notion of what you want these recommendations to look like, if it already exists somewhere and you're looking for somebody to rubber stamp it, I'm not interested. Because I feel like what we really have to do is get out there in the community and talk to people and find out what's not working and what is working and how we can do that better. And so the commitment was absolutely, there's no preconceived notions. They committed to doing public hearings around the state. And then the second was, I said, I have my career in Lansing, I started right out of my undergrad working for one of my predecessors, so I've worked in Lansing for 21 years. In my 21 years there, we've had 2 mental health commissions before. And as you heard Mark say, those 2 commissions, people put in a lot of time, people put a lot of energy into coming up with recommendations, and I'm sure they are beautifully bound somewhere on somebody's shelf, but they're really not being implemented, a lot of the recommendations people came up with. And I said, I don't want to be part of that. I only want to be part of something if we're really going to try to make a difference. And so we came up with this sort of founding set of principles. And you have the chair is the lieutenant governor, the co-chair is the director of the Department of Community Health, and then you have 4 legislators, just 6 commissioners on this commission. And it's literally the left of the left and the right of the right of both the House and Senate. So you have a really diverse set of opinions and values, I think, that people bring to the work. But we committed to each other that the only things that would end up in the recommendation were things that had unanimous support by us and that had something that was actionable in the recommendations within 1 year. So not that they can be all fully implemented, not that they can all be fully funded or fully actualized in 1 year, but some action step that can be taken on each one of them. And that then we would all commit to putting the weight of our caucus. I would use whatever power and influence and advocacy I could do to my Democratic caucus in the Senate to get their votes. Our colleagues in the Republican caucuses in the House and Senate would do the same, and that we hope we could really get some action. And so we went out and we did 6 public hearings around the state. We went up north to Traverse City and Marquette. We went to Grand Rapids, Detroit, Sanilac, and Lansing. So we had 6 public hearings as a whole commission. And we immediately realized that the governor's charge was for us to get him these recommendations by the end of the year. And it was way too much to try to all do together. So we broke up into 5 work groups, and each of us, excluding the lieutenant governor who chairs the whole commission, chaired one of the work groups. And we did another set of series of hearings and work group meetings around the state. And it was the most important and wonderful part of the whole process, because when you really heard people's stories and you asked them to tell you, don't just tell us the good stories, and especially in special education, where a lot of our teachers and administrators and parapros and family members, don't just tell me what's good, tell me what's not good, and I promise I'll redact your district's name, I won't tell anybody, it's not a blame thing. We really want to know what's not working and how we can do it better. And people were so generous with their time and so open with their stories, and it really informed every one of these recommendations. There's a real person, a real story behind each of these recommendations. And the first was, the first set of recommendations that we've moved now through the legislature was taking the phrase mental retardation and all references to the word retarded out of our state statutes. We were going to strip our state statutes of the R word. And that came out of this idea that we have to do everything we can as a commission to help reduce the stigma of mental illness and developmental disabilities and substance use disorders. And part of that is language, right? Mm-hmm. So we're going to start there. And this was a very intense, this came up in one of our meetings, in one of our public hearings, because there was a group of advocates that wanted to show the power of the word. And they stood up, and one by one, they used racial and ethnic slurs that none of us would say in our day-to-day life anymore. And they stood up and said, I'm not, fill in the blank. And the first one, and you're like, wait, what's happening here, right? They're trying to prove the point that we don't say those words anymore. And certainly if we do, they're not in polite company, and we are offended when people do. But with this population, we're still comfortable letting people say those words that are derogatory and demeaning. And so, and substance abuse, right? So we also say that. And we had real people come up and say, you can have a problem and need care following your physician's orders for a medication, using a medication that you were prescribed in the way you're supposed to take it, and still end up addicted. So you're not necessarily an abuser. And so that's going to be the second just sort of destigmatizing step we want to take in the state, is to change everywhere in our statute that we say substance abuse to substance use, because it's not necessarily abuse. And those are just small, easy steps, honestly. It's like the first little things that we can do. But we wanted to set this idea, this sort of culture, that there are things that we can do. to help work to address the issue of stigma. So our work group started their work, started meeting. Mine, the work I chaired, was called Education, Employment, and Veterans Issues. And so really dug in and had lots of folks who were generous with their time and expertise to give us advice. And all of the recommendations that you see in the commission come from that work.
And if I may, Senator Warren, on the language is powerful. This is not part of the current commissioner, but maybe down the road, in Japan and in Korea, for example, the term schizophrenia has psycho kind of connotation. They changed the name from schizophrenia to integration disorder, and there's a couple of studies that show that 20% more people accepted their diagnosis. So these are the low-hanging fruit that you're addressing, which is wonderful. Down the road, there's a lot of language issues that can be addressed in the future.
So I guess one of the other things I didn't talk about was the role that advocates played. So as you heard me mention, we did these public hearings, we did the work group meetings, and the diversity of people who came to talk to us really was very deep and broad. So we had family members, we had citizens themselves who had a diagnosis and wanted to talk about their particular struggles. We had, educators on behalf of students in special education. We had some of the professional associations, our school counselors and school psychologists and school social workers who wanted to talk about ratios and how we can do better in our schools by making sure we have more school-based mental health care professionals in schools buildings around the state. So the advocates played a role in I think helping find the examples, the putting the face to what we were talking about, and then followed up with us as the process was going forward to make sure we had all the background that we needed. So definitely the organized advocacy groups were a big part of it, but lots of individuals just came and told their own stories.
Great. So what other aspects do you think will be implemented in relatively soon, or in process?
So one of the things that came with the recommendations was this realization that we could not do in 1 year everything that we had been charged to do. It really was bigger than we could do in a year, and it wasn't because we didn't work hard and we didn't, put the time and energy in. There were just things we realized we couldn't quite. We knew we're a problem. We identified as a barrier, or identified as something we wanted to solve, but we didn't know how to do it immediately. So one example I use is, in this state, we've gotten pretty good at covering pregnancies and delivery of babies through our Medicaid program, and then we keep the babies on Medicaid, but 60 days after birth, the mothers are kicked off Medicaid. And we know that, again, with our focus, that postpartum depression, the signs of postpartum depression don't always show up in the first 60 days after delivery. And we know this is something we have to figure out, and so you'll see the recommendation in the report is to study it, to come up with some ideas about how do we expand, especially mental health care to our, postpartum mothers. We just didn't know how to do it yet. The other issue was the issue of transportation. We realized that can be in this state in a lot of places. We don't have good public transit, and for folks who need to get to work and need to get to their job and need to get to treatment and need to get to medical appointments, if they don't drive, we don't have a lot of support for them in a lot of communities. And so the issue of transportation and how do we seamlessly support transportation for these folks is, again, just something that's going to take longer than a year for us to figure out. So we recommended and the governor accepted extending the commission's work for 1 more year, so 1 more calendar year. And we also want to use that time to start to implement. Like I said, there's an action step for every one of these recommendations, and we want to look and start to see what the outcomes are, because we know we have to convince some of our colleagues that some of these programs take money. We need to put resources behind them. And a lot of us feel like, this is the right thing to do. It's a good thing to do. But we also think there are a lot of savings to be had if we make good decisions like using mental health courts and substance use courts to get folks out of the criminal justice system. And if we can divert them before they ever end up in the criminal justice system, how much of a savings could we have there? When we did our public hearings around the state, we had in almost every community a sheriff or somebody from the sheriff's department come to talk to us about the number of folks currently in our local county jails who really have a mental illness or need substance use treatment, and instead are being housed by us in jail, which is not cheap, which is not the right place for them when they really need treatment. And what the sheriffs told us was in most of our communities, it's between 25 and 30% of the populations they have on any given night that really need care and aren't, and don't need to be, incarcerated. When we went up to the UP, the Marquette County Sheriff told us in his community it's 80%. 80% of the people he has in his jail on any given night, and it's because we don't have any options. You didn't have a lot of close, safe facilities or places for people to go. So there's a lot of recommendations that take resources, and that's the next place we're starting. The governor gave us a little pot of money that we can use in this year's budget to start moving some of these forward. So some of the things I think that you'll see in quick order, kind of in the budget. On the school side, we pledged some additional support for our school-based healthcare centers. So, and to make sure too that, so right now we have about 70 of them around the state, and about 61 of them have mental health care professionals as well as physical health. And what we found, there was Michigan State University did a 3-year longitudinal study on them, and found that in Michigan, we do this really well. We actually draw down a lot of federal dollars to support the program. And what their study showed is that having that access to physical and mental health care in the school building had this tremendous effect on all of the students in the building, even those who didn't ever go to seek care. So absenteeism in the buildings went down. The general overall health went up. Instances of bullying went down. The openness of language to be willing to talk about anxiety and depression and the growing pains of all the stressors in life. They had a better language to do it, and they were doing it more often. And what part of the study showed, it's, kids talk to each other. So even if they're not the one going to get the treatment, knowing that they can get it and that it's safe is something that they all started to talk about. And so one of the recommendations will be expanding the number of school-based health centers that we have and trying to get mental health care to be part of that in all of the buildings that we can have that be part of. We also will be doing. We also will be looking at how to make our special education funding in the state a little more flexible. So right now, once you have an IEP or you've got a diagnosis that puts you in that track, then it's covered. And right now, our districts are saying they don't have enough flexible money to help those students at the first signs that something's wrong, right? And they might be students that are going through a transition. They have some anxiety or depression, but it's not necessarily something that's going to put them into special education for the rest of their school career. But right now, they don't have a lot of early intervention money. They don't have a way to help them. And we even districts that have school counselors or school social workers, their time really has to be dedicated right now because of the funding, of the flow of the funding, to only those students who have an IEP or only those students who are Medicaid eligible. And what we really want to do is try to give them some flexibility. So that's something that will be coming quickly here too, I think. One of the other things that came up that was a real barrier to accessing care was Michigan has, just generally we have a healthcare provider shortage. I think you probably all know that. We struggle in a lot of places to have all the providers that we need. But psychiatrists in particular, in the state, what we heard in the testimony is in a lot of communities it can be 8 to 10 weeks before you can get in to see a psychiatrist. And for our, for our citizens that actually are going to need a prescription, hopefully in tandem with therapy and other treatment, and wanting that specialized, physician to give that prescription, it's a real barrier. And if somebody's in crisis, waiting for 8 or 10 weeks is not a good option, right? So we're going to increase the flexibility of our telemedicine statute. Right now we do allow for telemedicine in Michigan, but we don't have the ability to do it asynchronously. So right now it's the only way that you can bill for physicians' time who do want to use telemedicine. It can only be sort of live. They have to be consulting with the patient live. And what we're finding is that if we could make it billable and allowable for them to do asynchronous, so maybe it's an advanced practice nurse or a social worker or a PA or somebody who's with the patient, and then the psychiatrist can review the records, can then ask questions to the other healthcare provider and pass along the care, that we might be able to really increase the amount of people in the state who can get access to psychiatry. And what we're finding is a lot of our general practice docs who end up being the overwhelming prescribers of a lot of medications, especially our psychotropic medications. A lot of our psychiatrists are saying they're pulling these people back off. Sometimes we're overprescribing, we're not prescribing the right things, and the more that we can get those, the sort of specialized physicians out there helping with prescriptions, I think the better off we'll be. So that will come pretty quick, and there'll also be funding to help expand some of those programs. We're already doing some around the state in partnership with our CMHs, like our local community health agencies, but we need to expand it, and part of it's the technology purchase. But it's getting, everything gets easier every year with technology, and now there's a HIPAA-compliant iPad program that they can use to actually, so if you could have a case manager that, again, might be a social worker, might be an APRN, might be, somebody on the ground in one of our CMHs who has a HIPAA-compliant iPad, who can do home visits maybe and go to where our patients are, or have them come into a local CMH without needing the full, cameras from the ceilings and all the TV, just make it a lot more accessible. So we're kind of excited about that.
What does HIPAA compliant mean? HIPAA compliant iPad, meaning it has security?
It's got the security for the privacy, so that there's nothing else in there that's gonna, record any of that information or capture any of that information, so that we just make sure it's everything we need for the privacy of the patients and their parents and folks who are involved. So.
Can you speak to the emergency clause in HIPAA?
Yep, and so that's another one that that came out of the work group conversations that we had, was this realization that our Michigan's mental health code was not in line with what the federal law allows for our, and we heard a couple of parents testify in particular about this. So there's this age gap in particular where maybe our young people are 18, 19 through 26, they're still in special education, they're still probably living at home and dependent on their parents, but they get to a point where they are an adult and they're legally allowed to have the right to refuse treatment, to talk about their treatment with their parents. And the federal law under HIPAA allows for a care provider to tell a parent or caregiver information that is in the best interest of their patient. So if it's something that they need to know to help guide their care and support their care, Michigan's mental health code didn't have that, doesn't have it yet. But we've got a bill, and that will be introduced, and I think the chair of health policy will be taking it up very quickly to bring those two things in line. Because what some parents were telling us was, it's common for teenagers and their parents to, have a little struggle now and then, and particularly when you have young people who are also struggling with mental health, concerns. You really want parents, again, you want to respect, if you read the report you saw, we came together with this idea that our whole focus needed to be through the lens of doing everything we can to promote and empower all of the individuals that we're trying to help to be independent, to be self-determining, to make their own decisions. So we're not at all trying to take away that right of privacy or get in the way of that. But in those cases where their care and treatment could be guided better if their provider could tell their caretaker or their parent something that was specific and important for their best interest, we want to open up that possibility. And we're seeing that was a barrier for some. And with this, sometimes, especially for folks who need medication, it can be a struggle back and forth. They sometimes don't want to be compliant with their medication, and sometimes that's not the best for managing their diagnosis. So,
years ago, when I first learned that one of the symptoms of schizophrenia is denial of the illness, that makes this a little complicated.
Yeah,
when somebody is psychotic and they're denying that they're ill, and then there are regulations in place to protect, it's states' rights issue too, but it can get very complicated, and I really thank you for doing what you're doing on that, because from a parent perspective, when your loved one needs help and anything we can do to remove barriers to getting people help. And yes, there are parents, there are not so good parents too. So really the providers, should be in the driver's seat as far as making those decisions and be protected to make those audibles about should I disclose or shouldn't I, as opposed to, well, it's just a black and white, can't do it. That's,
Good.
Would that be including, so both DD and MI, young adults? How would you define whether, a parent has that authority or not? Because I see that a lot.
So the way the statute is written, and it's written to mirror what the federal law already allows, which is to leave it in the hands of the provider to make the decision if it's in the best interest of the patient to disclose information. So it really is, as you heard Bob say, we really want we don't want to get in the middle of the power struggles between patients and parents or patients and caregivers, but when a physician, when a provider sees that there is something that could be done better, that where their care could really be improved if a different course of action was taken, we want them to be in a position to make that decision. And of course, your license is on the line, your malpractice is on the line. I don't think people are going to do it lightly, but in those instances where it will really make a difference, especially if there is a denial of illness or there is a reluctance to take needed medication, I think it will give us one more tool in the toolbox for our providers.
Start out since you were just on the veterans. When I read through it, that was a concern of mine about the mobile on board. So thank you for clearing that up with me to understand that once they come home, they can end up in any place wherever they feel help can be found.
Right.
But my concern when I was reading about the mental health code, when it was talking about the undue harm, what is it called? The undue hardship.
Oh, yeah.
That's the part, when I was reading that and I was reading like what they would be able to qualify for, it's like for jobs and finances, say if they needed housing and things of that nature. But my concern was that if we take and put mental health in that category under that, I was concerned about the long-term, short-term. Like if you think of a job, they help you to find a job, or education, they help you to go to school.
Right.
But mental health could possibly be a long-term process for a service person.
Yep.
So could you speak to that to kind of help me to understand how that really fits into that category?
Yeah, and that's a great question. So we have, established for a long time in the state the Michigan Veterans Trust Fund, and it started with a corpus of $50 million, and that has been invested and has made interest, and that's what we spend every year. We never touch the corpus; it's still $50 million, but we spend the interest and invest it. And the trust fund is used to help veterans with some kind of emergent need, some kind of emergency that it might be their power's about to be shut off, or their house is about to be foreclosed on because they missed a payment, or multiple, but. And in that definition of things that are an emergent need, that are an undue hardship that needs to be addressed, that they could need financial help for, physical health has always been included, and mental health has never been included. So this recommendation came from a couple of we see it coming at from a couple of different angles. One is, if we're really trying to reduce the stigma of mental health care, physical and mental health have to be more integrated. And so we think of it the same way. So you wouldn't be able to apply to the trust fund and get support for the long-term treatment of PTSD for the rest of your life if that's what a veteran finds that they need to take care of. But an emergent need of if they need transportation to get to a psychiatrist for an evaluation, if they need a prescription for the first time that's more expensive than their insurance covers or something, it's that sort of emergent immediate need, not the long-term care.
Okay, thank you.
A lot of the recommendations really had to do with working across systems. Which perhaps will be some of the most difficult to implement. what do you, we've seen prior governors really take a kind of hard-nosed approach and not really accomplish much. What do you think will be the administration's, assuming that they continue in power, what do you think there will be their approach to working across systems?
We've gotten a lot of support. Like I said, I mean, the governor himself, the lieutenant governor, have been very involved. The director of community health sits in every one of these, meetings himself. He doesn't send a designee. He sits on the commission himself. And so there's a lot of investment, I think, by the administration, certainly in what we've done so far. And the question about working across departments and agencies and frankly even across programs was one of the first really obvious barriers that came up in our conversations. And there was this amazing aha moment. It might have been our second or third meeting of the whole full commission before we went out to do any of the public hearings. They asked each department and agency of state government to send one person to the commission and to talk to us about what they are already doing for this population. And it was everybody from state police to DNR to the ones you'd normally sort of think of, community health and human services. But literally our Michigan Works Agency, the employment agency, literally every agency came and started talking. And even, like I said, DNR, which a lot of us didn't know. We actually run programs in some of our state parks and state forests to help run camps so that our kids with mental illness or developmental disabilities can get out and enjoy our park system, and that we actually have more parks in our state that are accessible for people with disabilities than any other state in the nation. We had no idea, and we're the only ones in the nation that have an accessible waterfall. Quamanon Waterfall is is completely physically accessible, which is neat to hear. But as we went around the room and people talked about what their agency was doing or the department was already doing for this population, watched people go, wait, wow, you're doing that? Or what, you had that? I had no idea. Like, they didn't even know. The right and left hand had no idea what all we were doing. And one really stunning example, so in my work group, veterans issues fell into my work group. And as we ran around the room, the new Veterans Administration agency had 675 long-term supported housing vouchers from HUD for veterans that are returning that have, again, either anxiety, depression, PTSD, some kind of even short-term, maybe curable condition. And MISHDA, our housing agency, had no idea, and we're like, they weren't talking to each other. So MISHDA knew who some of the veterans were who needed to use these vouchers. They didn't know that the Veterans Administration Agency had vouchers that they could use, and it was like just being in that room together helped break down some of those silos. But that's one of the biggest problems I think that we have for the programs that we either fully fund or mostly fund in partnership with the federal government. There's not a lot of coordination, and you watch some of these citizens will be in programs that we fund for much of their life, and it might start with special education, and maybe they're in foster care, maybe they end up somehow on Medicaid and get their health care support through us, maybe they're get services at a CMH, maybe somebody ends up in a corrections system. But right now the information is, they're not talking to each other. We don't have standardized criteria, and you see in the recommendations, like standardizing some of the information that we collect and gather is really important, because we heard people tell stories, and again, every single one of these recommendations came from somebody's real story. Somebody who's been incarcerated, whether in our local jails or in one of the state prisons, has had a diagnosis, has been on a treatment plan, on medication for whatever number of, let's say, 5 years, gets out. They are referred to their local community mental health agency. Their diagnosis doesn't follow them. Their prescriptions don't follow them. They have to start all over again with an evaluation, with a diagnosis, and it just finding a way, again, respecting people's individual right of privacy, respecting their ability to self-determine. But if we had a mental health in particular, but a healthcare passport that would follow them with their own login and password to at least be able to share that information. If we standardized evaluations, if we standardized the criteria for people to be able to work in these programs agency by agency, instead of saying, so as you all get your MSW, some programs, an MSW will, you can provide all kinds of care in community mental health. But DHS didn't have the same requirements, and corrections didn't have the same requirements. And so a lot of the standardization, so that the credential that you have, you'll be able to do the same work for the state in any agency if it's similar work and your credential is what's needed. Right now, that's not the case. It's just really, again, low-hanging fruit kind of stuff that just makes no sense, but needs to be fixed. So I think there will be a lot of willingness to work across departments. The biggest challenge is really going to be, how do we break down the funding silos? Because it's more about the funding than anything else, and helping the funding follow the individual, and particularly in the area of veterans. So we've got a lot of veterans that come back from, especially right now in Michigan, a lot of folks who've been deployed who come back, and even if they are willing to acknowledge that they need mental health care, because in that particular population it's a little bit harder to, I think, than even the general public to admit that you have a concern like that, and they have a different set of fears, right? If they want to stay in service, or they want to be in some other kind of law enforcement someday, you can lose your security clearances based on what your diagnosis is. You can lose your access to carry a concealed weapon, and guns tend to be a little more important in this population than some populations. So if we have a veteran returning home who acknowledges that they need care, there cannot be a wrong door wherever they end up. If they end up in community mental health, if they end up at the VA, if they end up in a local, either an advocacy organization or their doctor's office, the money has to follow them. We can't turn them away. And this is happening in our state every day right now. Veteran goes to the VA, and the definition of veteran, we have to standardize the definition of veteran, because different programs have different definitions, and maybe if you're not deployed, during a particular time to a particular theater, then you might not be covered in the state for certain things. And so I think you'll see a lot of interest in working across departments. We just have to figure out how to make the funding flow so that people feel comfortable,
Comment or question came up for me when you were talking about the mental health courts.
Yeah.
I'm a believer in those, but at least in Jackson County, the eligibility for those courts requires a person to have Medicaid, and if you don't have Medicaid, you're not eligible for those courts. So it really excludes a lot of people for those courts and puts parents in a position of whether they should drop their child from the insurance. And I had a problem with that. I was very frustrated with that experience. So I was wondering if you could speak to that.
Yeah, and our partner in all of this work that we did in the Mental Health and Wellness Commission is, at the same time that our executive order was issued, the Mental Health Diversion Council recommendation was issued by the governor as well. So it kind of, their work came in tandem with ours. And that is something I know they looked at, and part of their recommendations are to drop that requirement for Medicaid, and to also set up a juvenile system, because right now we don't have any similar sort of diversion for our juveniles bumping into the justice system instead of our adults. So you'll see a lot of good work, I think, from them, and their recommendations are a little bit farther along than ours, because they were able to do a lot of stuff administratively, like just through the rules process and in the departments. But you will see coming from them the desire for that change, and I think we can probably make it happen pretty easily.
Another thing for your information, we in Washtenaw County, we have a compassionate judge, Tim Connors. He just recently received a $150,000 grant to bring a peacemaking court. Pardon?
I'm trained.
Good. And based on Native American principles of respect, restoration, and it's, I believe, at least initially focused for juveniles. So that's kind of pretty progressive. That's Washtenaw County. But I think it can really serve as a learning model for many other people involved in the justice system. My personal experience is that many judges really want to do the right thing on this. They understand the importance, and it's a win on so many levels for people.
But it's pretty simple. Just, in regards to the high-quality, coordinated, consistent care and service, how does your recommendations overcome the barriers that have to do with, Medicaid, other insurances, and basically the access? Because, as you know, some insurance companies, they only cover certain types of things, which can affect, the quality of care that the patient actually receives. So how does your recommendations kind of help overcome those barriers?
I think the first steps that you'll see in our report and that you'll see moving in the next calendar year start with, we did in this state in the 90s, we really got rid of a lot of the old infrastructure of how we delivered mental health care services. We got rid of all our psychiatric hospitals, largely, most of them, and had this idea that we wanted care to be community-based. And it's, I think, motivated by good. The idea was motivated by good, but then when we sent all of this care back to communities, it's never really had enough funding to do everything that we need. And one of the biggest challenges is a lot of our community mental health agencies don't have very much general fund money. They don't have flexible money. So they end up having to primarily serve folks with Medicaid. And with the small amount of money that they have left over, they have to only they have to triage. And so a lot of them have decided to take care of only those with the most serious diagnoses, those that need the most serious care. And so a lot of our folks with sort of low to moderate needs just they're not being met. Their needs aren't being met if they don't have Medicaid. So the first thing we wanted to do is find a way to put more general fund support into all of our community mental health agencies so that even if you're not Medicaid eligible, even if you have private pay insurance, you should be able to go to your community mental health agency and get better care as we move forward. And one of the other things was that we realized as we went out around the state and had these hearings, CMH to CMH, people are getting really different programs are being run, different care, different, again, the same challenge that we've had before, different evaluations, different, interpretations, and so we want some standardization there. So it's not supposed to matter what county you live in, like you should be able to get good quality care, whether you're in a small, a lowly populated county or a big, or one of the big ones, Wayne or Kent, or so you'll see us trying to standardize a little bit more and to support our community mental health agencies with more general fund so that they can help serve more people. It's not going to do everything that we need to do, and your question is, it's a great one, it's an important one, but what we really felt like with this report, we can start to take first steps, and if we even can do, take one step on each of these recommendations that we have, I think it will be so empowering for so many of the advocates and the families that have wanted these changes. It will really make a true difference in the quality of life for so many of our citizens, and I think it will just give our colleagues the sort of political backbone to keep making the changes that it's going to take, and frankly, spending the money. That's a big part of what we're trying to do in this first year is show some successes, so that we can show people it's worth the investment. The return on this investment in terms of our citizens' quality of life, in terms of their families' quality of life, and the financial bottom line of the state will all be improved if we can do some of this work.
Build early momentum. This is my management consultant coming up, but Governor Snyder is a business person.
Yeah.
So everything in terms of, you mentioned, Mark, about advocacy going forward, it has to be presented as a business case. It has to make economic sense. It's about healthier Michigan. It's about the economics, and that resonates. The other thing, as a management consultant, and generally speaking, in organizational change, you're dealing with culture. And there's a school of thought that you can't change culture in an organization. It just is. It's a very powerful force. So what we're taking on here is not something that's going to be easy. Typically, I would say to my clients, it's going to be a 3 to 5 year effort, and that's the reality. But wonderful, totally get it in terms of build that early momentum. It builds confidence. People will go, oh, it worked. We can actually make a difference. And boy, once that empowerment resides in a lot of people, it'll make a big, it'll really be helpful to our state and the people. So, but the devil's in the details.
It is.
And, this Medicaid, who's 10 visits a year for straight Medicaid, 20 visits a year for HMO. I mean, we've got a lot of work to do on the details.
I definitely see that within my agency. I work in the ACT program, so we're the most intensive program in the agency, but it all boils down to, not their mental health status, but, and we tried to send, gateway letters saying, hey, can we keep these clients? And they said no to all of them. And the bottom line is the funding, so those clients that don't have Medicaid, or are in spin downs, they're going to be transferred to case management, which is 15 minutes a month, 4 hours a year.
Yeah,
We see them 3 or 4 times a year, so you can imagine, especially like our therapy clients too.
I went and observed the Brooklyn Mental Health Court in Brooklyn, New York, which is considered one of the best ones in the nation. And one of the first things that the clinical director of that court said to me, it's easier to see a judge than a psychiatrist in this community. And when it comes to this Medicaid issue in our community, therapists, there's a lot of therapists in our community, but they're not on the Medicaid approved provider list. So there's a real opportunity there. But all I can tell you from an N of 1, whenever I pick up my daughter after her 50-minute session with her talk therapist, she is in a much better place. So for some people, this is a really important part of therapy. It can really work for some. It can really be helpful to some.
So I read these commissions, and why isn't there more of a business plan in these commissions? Why isn't there more, if we spend money here, we'll see double savings here? There's code words, like you said, flexibility, and under the education section. That means that we spend more funding here, but flexibility to me just means flexibility.
Right.
So why aren't these more of a business plan? Laura Snyder would be able to understand that if we spend money here, we save money here.
So I think there's a couple of things. I think first, you have to remember that this is a public document, that this report is it's available on the state's website. It was given to all the participants that came to our work group meetings and came to the public hearings. And to truly respect the citizens whose lives are going to be touched by this, whether they're the patients and clients, whether they're the healthcare providers, whether they're the family members, it can't all be about dollars and cents, right? Like, it's not respectful to them. And what is in this report for the public consumption it's high level too. It's there, you got bullet points. You don't really have, and in our work, we do a lot in shared documents. We do a lot on Google documents. I can tell you, we've got spreadsheets and spreadsheets and spreadsheets of dollars and cents. We know exactly how much money is being spent in every different sort of silo here. Even the transportation piece that I talked about, what we were able to put together really briefly is there's a tremendous tens of millions of dollars of state money that's going into transportation in the state, but again, in very siloed ways through DHS, through DCH. So is there the sort of the back end, all the financials, all the business plan, the studies that show where the savings are, the idea in here of doing a pilot on bundled payments, which there's really not very many states yet in the nation that are doing a bundled payment option. So you sort of have a contract that you send out to an RFP to providers who will say, okay, I will take care of this population for this amount of money, and I'll take care of all of their care. And if we save you money, then we keep the savings, right? So it's a way to encourage them to keep to that savings. There's nobody doing it in behavioral health right now, really, anywhere in the nation. We want to be the first to try it and see if we can't make a difference, especially for some of our high need young people. So it all exists. Just remembering, I guess, what the purpose of this document is. Yeah.
Are there, piggybacking off this question, are there any tax dollars that's being used in, any of you guys' efforts or funding at all for this?
So I want to make sure I understand the question right. In our efforts as a commission, as meeting and staffing and that kind of stuff, or in these recommendations, implementing these recommendations?
And implementing the recommendations.
100% tax dollars. This is all state money. This is all, or it's us, state money and federal money coming together. In a couple of places, I think that we'll be able to leverage some private foundation money, because we've seen that already, especially in the telepsychiatry project I was talking to you about. But this is 100% the citizens' money. Absolutely. Yeah.
And I was asking that because
Yeah.
you said it was
Yeah.
behind the scenes, and the people's right. I know the people's privacy, but also the people's right to know where their money is going.
Right, right. And there's no, I guess I just want to be clear. There's nothing about our work that's hidden. It's all public. We're a public commission. All of our meetings are public. All of the stuff that we talk about. It's just, so trying to address the question of why didn't in this document you put all that information? And to me, it really wasn't the purpose of the document. So all that stuff exists. Anyone can have it, and you can right now. You can on the state's website and through just simple requests, you could find out if you have an interest in a particular program. How much is the total community health budget? How much is going to our CMHs in our local communities? All of that is completely public and not hidden in any way.
Can I ask you,
Sure.
you talked about the school-based community health
Yeah.
centers and focusing on success, and that's moving forward, and
Yeah.
you know, a lot of the details. Can you talk a little bit more about the decision-making process? How are schools being chosen? How many more can we anticipate? How's that going? I guess, how's that going?
So what we wanted to do for the next round of expansion is we want to put two criteria together, a place where we know is already considered medically underserved, and where the highest need is for services. So we'll look at those two criteria. And right now we're in the budget, we're in the middle of our budget conversation. So we had one meeting already. Like I said, we've got this pot of money that's allocated, and now we're everything in here had a unanimous recommendation, but now we're tussling amongst each other to see how much each of our recommendations end up getting and how much certain things cost. So I don't know how many more we'll be able to add this year, but that's where we will prioritize, or those areas that are already underserved, medically underserved, and where we know we have a high need. And we'll see. I mean, it will literally be in the next couple of weeks, because we're in the heart of the budget process right now in the state, and so we'll finalize our recommendations. The commission meets again next Tuesday, and we'll continue to work through not every single one of these recommendations needs money. Some of them are things that we can do inside the department with resources that we already have. So some of this work doesn't, some of those we go through quickly, and then others again, we have to negotiate amongst ourselves. And you've got somebody like me, who's the left of the left, who would argue, well, the governor gave us this pot of money, but if we go lobby our colleagues on appropriations, maybe we can get even more, Like, why set ourselves at that ceiling? We'll get more for the programs we care about, and you might see us doing that still, or at least me.
I have a question.
Sure.
Do you know offhand, like as far as the Safety Commission and Criminal Justice, where you're looking to sort of budget some money there? What are you thinking about as your first steps in that?
We didn't get how we started walking through them last week, so we had only about an hour as a whole commission last week to start looking at it. We didn't get to that work group's recommendations yet in terms of money. But, some things like, and it's another kind of low-hanging fruit thing. I love that phrase, Bob. It's like so we have a lot of times when something goes wrong in a community, our first responders are the ones who get called, and they show up. And if they don't recognize what they're seeing, if they don't know that it's because of someone's mental illness or developmental disability that their behavior maybe had somebody call the police on them, so that first support for training for our first responders, I think that will be something that you will see money in this year's budget for sure. Okay. Because our state police are doing that training, and they are trained. But most of our local agencies have never had the support and resources for that crisis intervention sort of training. And there are states around the nation that are doing it really, really well. And if you could, and again, it's all part of this idea of trying to divert people from the criminal justice system, from corrections, if we can, because once they're there, things, they tend to cycle, and people tend to stay there once they're there. But if we can have our first responders trained to recognize that somebody really needs some treatment or support, or needs a place to come back from the edge of a crisis, and we have places in the community we can take them, which is the second piece that we don't always have. Like where, and some of our sheriffs, I told you the story of how many of our folks in our local county jails are actually need treatment. But I had one sheriff who just, and it was the Marquette County one, who's got 80% of his folks who really just need treatment. And he said flat out, he's like, but there's nowhere else to take them. And at least here in my care, they have a safe place to sleep. They're being fed. They are, you know, they're not hurting themselves or someone else. At least we can provide that. That's a really low bar, but at least that's an important, you know, consideration. So I think in public safety, you'll see those two things immediately probably addressed, is some more funding for training, and then trying to figure out where in each community we have a place for folks to go when we find that that's what they really need is treatment, even if it's just short-term crisis management, not put them in the jails.
So what about, what more talk have you had about, because I'm curious to see the numbers for, especially, you know, here in Washtenaw County, I'm really curious to see the numbers about our juveniles that are in the system and what percentage of them could really be diverted to some other forms. I'm really curious to see those numbers. I'd really like to see them.
And that one, I apologize, that was one of the recommendations of this commission, is that we need a juvenile, a parallel for juveniles for a diversion council, but it won't even be created until the governor issues that executive order. So we're still, you know, probably months away from really knowing anything from that. But our attention's on it for the first time, which I think is really important.
And then even in the way that we classify juveniles across the state, because you have, for us, you know, at the age of 17 or even 16 and some months, you can go to the county jail.
Right.
But you're still, you know, responsible, your parents are still responsible for your care until you're 18 type of thing. And that's not, you know, it's not the same across the state. So, I don't know, I'm just...
It's really interesting stuff to think about, right? Like, I think we'll probably see a lot of the same issues that we bumped into with that lack of standardization, and it's also like making a decision as a state what we value, right? And so this whole idea of diversion is we're saying we value people getting access to care and not ending up in the correction system if that's not really where they belong. And with juveniles in particular, like if we can do everything we can to keep our young people from bumping into the correction system, then that is in all of our long-term interest. And financially, it has to be, I think you're right, Bob, it has to be that we have to talk about the dollars and cents a lot more than ever before. It feels less natural to me, because I think about things in terms of what's the right thing to do, and how do we make our state the place that we want to live, and how do we treat our citizens like we would want to be treated if we were in their spot. But the dollars and cents just really add up especially with, correction systems costs are so high. It's so much money. And in our overall state budget, just thinking about our state prisons, we spend a full quarter of all of our general fund flexible money, a full quarter goes straight to corrections. And if there's a way to, you know.
It's about the same amount as for education, isn't it? And the budget line more?
We're one of 5 states in the nation that pay more for corrections than we do for higher education. Our K-12 education is bigger, and it's separate. It's not part of the general fund money.
As far as the treatment recommendations, there's quite a huge emphasis on trauma as far as shaping, having the agencies shape their guidelines and policies with a constant definition of trauma. Where did that come from?
Came from some of the work that we did that showed that in a lot of our communities we don't have sort of trauma-informed therapy. We don't have all the programs that we need to have. There's just a few places in the state that we really have sort of the deep reserves to be able to do that work. And especially looking at our children, it's the number of our children that have experienced 1 or 2 significant traumas in the state it's mind-numbing. It's really just amazing. And so we want to make sure that especially as we're allocating additional resources, that we're looking at the best treatment that we can provide and making that a priority. So
Does that exclude those without trauma? Because you're specifically wanting like the direction towards trauma. You're wanting these recommendations to go towards trauma versus maybe someone with a developmental disability or someone with bipolar.
I don't think it was meant to be interpreted that way, that it's supposed to be divisive, but that when we look holistically at what resources should be in a community, that access to trauma-informed therapy should be part of the puzzle. So not that it's supposed to weigh heavier than anything else, but that we don't want it to ever get lost, and that's why you see it repeated a couple of times in this report. I think we don't want it to get lost, that it's an important part of our whole continuum of care, that it should be in all of our communities.
What were some of the things that didn't make the cut?
Now, to be honest, one of our, because this is really political stuff, right? There's a political angle to all of this, and so our recommendation process. So each of the work groups came forward with recommendations, and then we debated them, and some were very easy. We all could easily agree with them, and they went immediately into the report. Some were absolutely, we were not going to get to consensus on and sort of fell away. And then the ones in the middle that we really had to fight and wordsmith and figure out exactly what that program would look like, we committed to each other that we wouldn't say out loud which of the recommendations didn't get votes and who didn't vote for them, just to protect each other a little bit, so that there weren't bad feelings about where we ended up. But I'll tell you, there's some things that we took off the table immediately that are not in violation of the spirit of that agreement. Mental health parity was one of the first ones. I said, well, why don't we just recommend mental health parity? Nope, that's just too controversial still, where that one's coming off the table. There's a group of folks that wanted to talk about, immediately.
Wow.
Yeah. Scope of practice issues for individual providers. So this is it's another really political issue, but really important issue as you look to provide care for a lot more folks, and especially in partnership with the Medicaid expansion and the nearly 500,000 new citizens that will have access to care. Do we want to change some of the scope of some of our practitioners so that we can provide more care to more people? And that was immediately off the table. So yeah, there were a few things that just really didn't make it. And I'll say, in all honesty, it's about a third, I think, of the total recommendations that were made did not get accepted. So this is about 2/3 of the work that people did that we were able to convince each other needed to make it into the final report. It's about a third that ended up on the cutting room floor.
Could you speak about the residential care? I guess just wanting to get some clarification. Like the first recommendation, it sounds like you're talking about crisis bed placements. Am I on the right track there? And then one of them talked about secure residential treatment.
Right. So the big value, I think, that people brought to the residential and long-term care sort of conversation was that we see that when we got rid of a lot of the psychiatric hospitals, we really don't have as many places for people who need more than a short stay in a hospital, but less than heading to Caro for a couple of years. And so this idea of looking for those sort of medium-term almost placements, so somebody who might need 30, 60, 90 days of stabilizing care, right, to come out of crisis, to get their medications right or whatever. And what we're really considering there, which I think could be really interesting as an experiment, is that we might be able to do these more community by community, that in a lot of our hospitals that we already have, we might be able to use a wing of beds that are so people aren't being taken out of their community, and away from their family and their positive influences, but be able to so it's basically that sort of medium term, this recognition that we don't really have any solution for that right now. The security issue is, for a lot of folks that are in residential placements, whether it's adult foster care or some other placement, right now people feel like sometimes their hands are tied when somebody is, that was bad metaphor, I should not have said that way, I guess, for what I'm about to say, but feel like they don't have very many options when somebody is just behaviorally becoming a challenge right now, and you don't want to medically sedate someone, you don't want to physically restrain someone, but you need them for their own safety and the safety of others with them to be segregated maybe away for a little while, or you need them not to leave for those folks who wander, so some of our folks with dementia and some of our older citizens. And right now in our codes, you can't lock a door. And so what we want to do is find a way to help, but it's got to be very narrow, it's got to be very careful, because we're not looking to have people imprisoned essentially, right, in some of these placements, but to be able to extend some security allowability for some of these placements, so that, again, it also just opens the doors for some people right now that can't have certain placements because their behavior or their diagnosis makes it difficult for them to stay there. So that's the goal, and it will be interesting. It's one of those ones that's going to need very careful policy crafting and very careful enforcement, right? So.
It seems like there's a push to move from kind of an acute care model to a chronic model, which I again believe in. But the privately held insurance companies are still very much entrenched in this acute care. So there's hospitalization coverage, but then nothing. Does the state have any leverage over privately held insurance to push them to move towards a more chronic care model?
So the biggest challenge that we have in Michigan, we have so many of the plans that are either federal ERISA plans or they're self-funded plans, and our ability as a state to regulate them is very, very small. Like we don't get to do that very often. So even if we do pass like the autism insurance reform, we pass basically a mandate, but it only applies to those insurance companies that we can actually control, which is a very small part of our whole overall population. But we can do a few things, right? So we control a lot of healthcare dollars in the state, because through Medicaid and some of the other programs that we fund and support, the Children's Health Insurance Program, the Healthy Kids Dental, like all these programs, we can really encourage providers in a lot of ways with the power of our contracts and the power of the investments that we make with our resources. And so that's why one of the pilots in here is a bundled payment pilot, because when you're talking about every aspect of care, whether it's, and again, it's not being done yet in very many places for behavioral health, but if we have a population that we know, and we've got a couple in mind that we want to try this with, that we know they're going to need care for their ongoing diagnosis, they're going to get colds, they're going to get the flu, they're going to need, other kinds of, in the bundled payment contract, it's for their care for the entire length of the contract, for whatever care is needed. So hospitalization time, if needed, 100%. Office visits, therapy, whatever. And it'll be really interesting. It's one of the programs that has some private foundation support as well. There's some private foundations around the country that want to support this work. And I think it will change the way that we approach this work, because one of our biggest costs in another program, say like the dual eligible program for our citizens that are both Medicaid and Medicare eligible, readmissions to the hospital and length of stay in the hospital is a big cost driver. But if you can do to help those people who don't need to be in the hospital, keep them out, and free up the sort of dollars for people who do need more in hospital care, we'll still see savings. So I think that's one way we can start to, again, with our contracting, we can start to push people to do things differently. And when you show results, which is the same thing we wanted to do with autism, we couldn't mandate that any of the ERISA plans or the self-insured plans do the same coverage that we're doing in Medicaid and that we're doing with our state-based insurance plans. But we created in the first few years a pot of money for reimbursements for those companies that decide to do it. So we'd basically help them pay for it for the first few years of the program. And the idea is that once people start covering it, they will continue to cover it, and that there'll be also the sort of citizen pressure to cover it. If my neighbor's plan has it, why doesn't my plan have it? And talking to your benefits administrator about why it's not in your plan. So it's not as smooth and direct as us being able to say, you have to do it, you have to follow our lead. But we're a big part of the healthcare dollars in the state, and if we do it, it will start to change the game.
I know you guys are going to be looking at quality of care
Mhm.
and everything. Are you guys going to be studying or looking at the quality of care that's given from, like, say, an agency or a specific therapy or therapist that's getting paid more than one or agency that's paying less?
So this is
To
some.
encourage you to pay more so
Right.
that we get more money.
Right. So I think the two, and this is brand new, this just, that law doesn't actually take effect until April 1st, so the committee itself sort of comes into being on April 1st when that, and I'm named in the statute by my position, so since I'm the ranking Democrat on the Health Policy Committee, I'm on it, as are my chair and the House chair and vice chair. But the two things are really married in the way that the committee is even set up. It's both cost and quality. And so I think the approach will probably be, and the Director of Community Health is also going to be on that committee, and he and I had one quick conversation. We just said, we want to do something similar that we did on this commission, keep it small so that you've got people who will really do the work and dig in and take seriously this charge of, you can't take the two apart, right? We don't want to provide low-cost care that's not quality. So it can't always be driven by the dollars, and where we're getting better care and paying more, that's still a win, you know.
I want to ask you one other question.
Yes.
Which is, how can this group keep in touch with the progress of the commission?
So there is a website that is on the front, I think, of the report. So if you've seen the report, we do still post things to that. I'll make sure I say on Tuesday that we should do some more updates as we're going through the budget process and stuff, because people can follow it there. I do little updates. I have folks who are on my list from my work groups and stuff, so if anybody wants to, you can feel free to email me. I'm really easy to find, and I can add you to that list and keep you updated. But what you'll start to see are, these bills will start getting posted for committee, so any of you that want to follow the policy movement, it's incredibly easy to sign up for the committees of jurisdiction, so to sign up to get the notices for the health policy committees and the education committee. And what you get is an email, like once a week or whenever the committee meets, of the bills that are going to be up that week. And, you know, I tell people all the time, you could look at it, and if it's nothing of interest to you, easily just delete them. But you'd be, you know, the first to know when a committee posts if it's something that you're interested in watching for the next little while.
Great.
Yeah.
Thank you so much.
Absolutely. I appreciate it. Nice to be here.